My name's Jeremy. I'm the sickle cell psychologist at Hammersmith Hospital. So I'm a clinical psychologist and I'm embedded within the red cell hematology team. So I work almost exclusively with adults with sickle cell disease. That's a job I've been doing for about the last 8 years. And I'm going to be talking to you today about pain. Um, but before I do that, I wanted just to talk a little bit about kind of the impact of living with sickle cell disease. I, of course, don't have sickle cell disease, but talking to patients, we've heard a lot about hemoglobin and the kind of um, the genetic and molecular underpinnings of this illness. But in terms of what the disease means for people, um, and how that impacts their relationship with the people looking after them, I think when I talk to both patients and uh, healthcare providers, I think there is the sense that people with sickle cell are a bit different. It's a bit more difficult to work with people with sickle cell, and it's not always quite clear why. I think there's a whole bunch of reasons, and that's beyond the scope of my talk. But I think one reason has to do with just the way the healthcare system is designed. I think it's long been known that our healthcare system deals with problems with, sort of acute problems, short-term problems for people who are otherwise healthy really well. So if you break your leg or get appendicitis or have a heart attack or something, and you go to the emergency room, generally, we do a pretty good job. But for long-term health conditions, lifelong health conditions like sickle cell, we don't do so well. Um, the other issue really has to do with what is it like to experience this illness. And there's a metaphor I've been working on for a while now, so I'll bounce it off you. But I think that having sickle cell is a little bit like getting mugged. So if you imagine that you're standing in an ATM withdrawing some money, and a man comes up behind you with a knife or a gun or something and says, "Give me all your money, or I'm going to make you hurt, and I might even kill you." Um, that's a little bit like what it's like for people with sickle cell, um, to have this illness where they're going about their life, and this thing comes along unbidden and says, "Do what I want, or I'm going to hurt you, and I might even kill you." Um, and if this happened to you in your life even once, I think we'd all acknowledge that that would be a pretty traumatic event. But with sickle cell, it happens repeatedly. And it also happens, I mean, somewhat regularly, but also unpredictably. You never quite know when it's going to happen. So if you were in a world where you could expect to get mugged regularly, but you didn't know when, well, you wouldn't be just worried and stressed and traumatized when it's happening, but even in between muggings, you would be incredibly stressed. And I think that impacts the way people try to manage things and interact with healthcare providers. So, although I'm going to be talking about pain in general, I think it's important just to think about this is the context in which people are trying to manage their illness. Anyway, moving on. So, we're talking about pain. Well, what is pain? I think most people have experienced pain, but if you try to give a definition of pain, it's often very difficult to articulate exactly what it is. So the International Association for the Study of Pain gives the following definition, that it is an unpleasant sensory or emotional experience associated with or resembling that associated with actual or potential tissue damage. So that's that's a highfalutin definition. Um, what does that actually mean? Well, the key point is that it's a sensation. There's a feeling about it, and also a valence. That is, it's it's it actually feels bad to have it. Um, the other issue is that pain is not all about damage. Pain, as an experience, is more about your body warning you of danger, something wrong, even if there isn't damage, because damage isn't required. The other point to make is that pain is a subjective experience. In a universe of rocks, there is no pain, right? You have to have conscious creatures having experiences in order to have pain. Pain is something that your brain does. And it's also important to note that the context in which it occurs and the incentives involved change the experience. Well, how do we know this? Well, so I'm a Canadian, so uh, I'm aware that our national sport is the only major professional sport where fighting is actually allowed and part of the game. Um, and obviously that's painful, but people still play when they're in severe pain or even injured. This happens in other sports too. Your attention affects, so the norms of the game affect your experience of pain. Your attention affects your experience of pain, and also the incentives involved in the sport can affect your experience of pain, or at least your display of pain. Um, we also know that pain is not just about an injury. This is the gate control model of pain. So we know there's the injury part, and that's feeding into the pain experience, but there's a whole bunch of other things going on that can affect people's experience of pain in an intact nervous system. And we also know that if we break the connection between the part of the body that's injured and the nerves conveying a signal to the brain, well, people don't have at least that pain anymore. If the signals don't get to the brain, there's no pain. We also know that people can have pain even if they don't have a particular part of the body. So, you know, people who've lost a limb, in this case, an army veteran, um, ex- you know, can experience what's called phantom limb pain. And that's not just kind of a generic pain. What they actually feel is a sense of cramping or burning in the part of the body that doesn't exist anymore. They feel like it's pain, say, in their foot, even if they don't have a foot. Um, and that doesn't make any sense. And in this picture here, uh, it's an example of what's called mirror therapy. By placing a mirror down the center of the body and looking at the reflection visually, you can kind of trick the brain into thinking that the amputated limb is still there. And when people do this, and there's a specific procedure involved, their pain goes away. So we know that whatever's happening in the brain can affect people's pain. This is a virtual reality setup for people with amputations trying to impact their experience of pain. Using a virtual reality headset, people can have the experience of having a virtual body. And so when you notice that pain really is something that only exists in the brain, that there's no there's no place for pain to be outside of the brain, then words like real or mental or physical and so on to describe pain don't really make much sense, because all pain is psychological. And I'll just say that again. All pain is psychological pain. There's no difference between sort of mental pain and physical pain, or physical pain and real pain. It's all psychological. We do make a distinction between acute versus chronic, or what's increasingly being called persistent pain. Um, Not that the pain itself is a whole lot different, but it differs in terms of duration, signal, and the expectation of relief. For acute pain, that is pain that's less than 3 months long, um, it's most of the time it tells us a useful signal that there's something wrong or there's danger, um, and the expectation of relief is high. That is, it's probably going to get better. When pain is persistent, that is, when it lasts longer than 3 months, well, the signal's not very useful. You know you've got something wrong with you, even if you don't know what it is. And it doesn't really help to keep having the signal. And also, if pain has lasted for longer than 3 months, it's probably going to hang around for a while. May not be permanent, but it's going to last. In sickle cell, so we've heard a lot about the pathophysiology of sickle cell, but we can have different kinds of pain in sickle cell. So acute pain, showing up for less than 3 months. An example would be the vaso-occlusive crisis. People can have other complications that arise in sickle cell that are acute pain. More persistent pain is the kind of long-term damage to the body that comes from acute injuries, and also neuropathic changes. So the nervous system can become more sensitized or damaged, and when people have had pain for a long period of time, it changes the way their body processes pain, and so you start to have pain even when it's really not helpful. So how do people deal with pain, whether it's acute or chronic? Well, in sickle cell, for most people, most of the time, when pain shows up, we treat that pain with pain relievers, usually opioid pain relievers. And those usually work really well, at least at the beginning. So we treat people with opioids and they get relief. And so in psychology, we would call that just stimulus response reinforcement. That's learning. What also happens when we treat pain in this way is that people develop tolerance. That is, the pain relievers start to become less effective the more they're used. And so over time, as people become tolerant to the pain reliever, they actually become more sensitive to pain. And so they get more pain. And to do that, they need more opioids. But as they do that, as that cycle continues, people tend to get less and less relief as their tolerance gets higher and higher. And so this is a problem. What we need is a framework to identify when someone has got a maladaptive coping pattern and intervene early in the process. And so the situation with sickle cell is pain shows up, pain of some sort, and people have a choice of how to deal with it. So sometimes people manage their pain at home, sometimes they go to their GP or their A&E, and sometimes people go to hospital and get admitted, right? These are all different responses, but in common, they all involve getting treated usually with opioid pain relievers. So what should this look like when the system is working well? Well, what we'd like is for the vast majority of our patients to manage their pain at home by themselves. And then some smaller chunk, if you can't manage at home, you come to hospital or your GP or some short-term triage kind of situation where you don't get admitted, but the problem can be resolved quickly. And only for people whose pain cannot be resolved quickly, a small chunk, we have an inpatient admission. So that's ideal. But there's problems with this. How do we figure out if there is a problem? I think we need to have decision rules, and I don't know what these are, but I'm proposing that we need to think about, at what point would we consider a red flag? And so I don't know, if someone is using more than 90 milligrams of morphine equivalent per day, maybe that's the threshold at which we say, okay, that's a problem. Just as an example, I was speaking at another session a few nights ago where a patient was telling me that they got labeled as a drug seeker because they were using 30 milligrams of codeine per day, which is, I think, correct me if I'm wrong, is about 3 milligrams of morphine per day, roughly. I don't know what the threshold should be, but it probably should be a little bit higher than 3 milligrams. Maybe we want to think about, are they attending A&E or their GP surgery very frequently, more than 3 times a month? Maybe that tells us there might be a problem going on. Or if they get admitted to hospital, and that there's a matter of both how frequently are they admitted and how long are they admitted. If they get admitted very frequently but they only stay a couple days, those days can add up. Maybe someone doesn't get admitted very often, but when they do, they're in hospital for 2 or 3 months. That would be a problem. So a high rating on any one of these factors would be a sign that someone is not coping well with their condition, with their pain. Um, and my argument is that a strategy is maladaptive if it seems to help, but it leads to greater harm later. That's obvious with opioid pain relievers. It can be with other strategies as well. But with opioids, they work really well at the beginning, but they work less and less well over time, and they tend to cause more pain the more people use them. So I'm looking at some profiles, and I'll kind of walk you through with the example of a patient that I was treating for several years. So if someone's not really using opioids at home, they're not really coming to hospital at all, they don't really have much pain, so we're not really worried about that. But if someone is coming into hospital a lot or is staying in hospital a long time, that's our first sign of a problem. So here's this example of this patient. So this person was coming into hospital a few days a month. This data is getting a bit old now, but they weren't really coming in very often. Then in 2014, you could see their inpatient days were creeping up to 4 or 5, maybe 6 days a month. But then they had this fairly long admission. Um, and what we see after that is most of the time when people have a long admission and they don't like being in hospital, they say, I'm not, I'm going to try to stay out of hospital. And what they often do is they try to stay out of hospital by managing their pain at home, usually by taking a higher dose of opioids at home. And that's easy to fly under the radar if we're not tracking this. So if someone's outpatient prescription dose goes up, that should be a red flag. But as they do, that can work for a while, but as they do that, it stops working. Their pain stops being as well controlled as it used to be. And maybe they come into an outpatient clinic or a temporary ambulatory triage unit. And so what we saw with this patient is after their long admission in 2014, 2015, they tended not to come into hospital hardly at all, but they're coming in for this this outpatient triage service much more frequently than they were before. And then the more they do that, the more the tolerance increases. So at some point, they're coming into hospital a lot because they're using outpatient services a lot. Their tolerance is increasing and they're trying to cut back. Most people start to notice they have a problem. They cut back, but they cut back too much. Their pain flares, and then they come into hospital. Or maybe they try not to come into triage very much, but again, their pain flares, and they get admitted to hospital with a full-on crisis. And of course, the worst of all worlds is if people are using constantly high opioids at all times. So with this particular patient, after not coming to hospital very much, what we saw in 2016 is the first half of the year that continued, but then gradually the number of inpatient days came up. In 2017, it's just astonishing. This person was spending most of their life in hospital getting 2 hourly injections. Um, and it it did drop. You can see in sort of between July and August, there was a drop actually when this person was pregnant, had their baby, but the thing that they thought was causing all their pain had gone, but now very quickly um, their their admissions crept up again. So I think it's important to identify, where a person is at as quickly as possible and get a sense of how far along the path this person is, how much opioids are they using, where are they using it, and what's working and not working for them. And then I think it's very difficult to deal with patients, partly because of, I think, the traumatic elements that they're dealing with. Um, and so they need to be referred to a specialized service, I think. Um, in most cases, patients will have developed, chronic or persistent pain. And so it's not merely a matter of just managing their number of vaso-occlusive crises, but we need to think about other sources of pain and manage them. So what I want to talk about is the complex sickle cell clinic that we've begun running at Hammersmith Hospital on Fridays um, with Dr. Akoli and myself and our pain consultant and others. So it's really a joint hematology and specialist virtual clinic. Um, and this involves input from the hematologist or a patient's hematologist, but also a pain consultant. And I think this is really key because pain consultants, they know stuff about pain. That's their specialty. And they know about advances in the field, and they can offer treatments and interventions that most of us will have never heard of. And I think this is very important for getting engagement. I mean, perhaps Stephen, uh, maybe Stephen will agree with me, but I think the success that we've had with many of our patients with the complex sickle clinic has to do with we're not just taking away an intervention. I think by the time people get referred, they're often hanging by a thread, and our job is not to merely cut the thread. We're giving them a rope. We're giving them something they didn't have before. And once they can grab onto that rope, they're not worried about the thread. And so it involves coordinating with GPs, particularly if it involves managing or changing medications and coordinating with other kinds of interventions or treatments. Um, I'm there, and I'll talk a little bit later about the kind of support that I provide for people. We have community nursing support. I think that's essential. And something that we don't have yet just because the posts are not being filled, but I think it'd be great to have more physiotherapy input. And when we fill the post, a social worker input, because many times, the trigger for patients' pain in the community is often a matter of things like housing and and bills, not being able to pay your heating bill, triggering a pain. And we also have, on an as-needed basis, advice from a specialist addiction psychiatry. So I'll just talk about my role within this team. So I think oftentimes when we're dealing with persistent pain, we're talking about pain that is going to last for a while. Um, but that doesn't mean that we should just say, well, there's nothing for us to do. We're not going to do anything for this, because just because you've got pain doesn't mean the pain is going to be the same. The pain could get worse. And so often the thing that patients are doing, and sometimes even their doctors and nurses are helping them do, is the same old thing, which is actually making their pain worse. So a big part of what I do is trying to get people to change their behavior, to try something new. If we can stop it from getting worse, that's better. Um, the other thing to think about when dealing with persistent pain, I've been working in this field for long over a decade now, and what I find makes people most miserable in their life isn't actually the pain. If you talk to someone with sickle cell, they'll tell you they have a pretty high pain tolerance, and they're kind of used to having instances of really severe pain. That's not what bothers them. What bothers them the most is that it's the kind of putting your life on hold and waiting for pain to get better, not doing the things that make life most meaningful, that makes people the most miserable. So stopping pain from getting worse is better than letting it get worse. And if we can help people live a life that's also meaningful and fulfilling to them, even if they have pain, it often means, it's important, but it also means getting them to do things they're not doing right now. And so what I do when I work with patients with persistent pain is we start talking about what's really important in your life, as well as getting rid of pain. What would getting rid of your pain do for you? What would your life mean if you could live a better life, if you could do what you wanted? What's really important to you? And if we can identify what people's goals are and get people to start moving towards things that actually mean something to them, um, they do better even if they have pain. Um, Another thing I talk about is activity cycles. So, and again, this would be helpful with a physiotherapist, but it's not really that complicated. Most of the time, when people have persistent pain, they tend to stop doing exercise or work or any of the kind of daily activities that are important. And in the short term, this actually is helpful. You can give yourself a rest, but in the long term, it actually makes pain worse. We know this makes pain worse. And so part of the work of dealing with persistent pain is getting people to gradually increase their level of activity. And surprisingly, they find out that it actually helps their pain. And here we get back to the issue I was talking about with trauma and mood and worry. Is obviously people have all the same worries and concerns and difficulties that anyone has in life, but there's a lot of emotional distress and worry related to one's illness, um, that also contributes to pain. And so we work on that. Communication and relationships. So I work on this, both with patients within their own life, in their personal life, because it can affect relationships. But one of the key relationships that it affects for patients, um, if if you have a hard time communicating, is your relationship with the people looking after you. Um, Patients, one of the things that makes working with sickle cell difficult for people is that people keep coming into the same hospital year after year, seeing the same people. And when that happens, everyone starts to relate to each other a little bit differently, a little more like family, but sometimes, not a good family relationship, but more like the annoying uncle at a family dinner that nobody likes. Um, it Relationships can become strained. We make a plan for how to deal with pain flare-ups, um, and trying to utilize strategies, beyond just a single strategy of using medications. Um, we teach people about mechanisms of pain, so they can understand what's going on in their bodies. Um, we do basic stress management, um, because we know that stress is a trigger for sickle cell pain. And a big part of what I do is trying to help people get a good night's sleep. I think not only do people not sleep well when they're in pain, but if people can sleep better, their pain improves 100%. So the goal is that, by improving people's overall quality of life, by targeting aspects of their life that are affected by pain, we can actually make their life better. And oftentimes we can actually, um, lessen their pain overall. Um, anyway,